A soldier drags himself back from battle, his leg crushed beneath a fallen horse. The wound is beyond saving. Infection has already begun, the flesh darkening, the smell unmistakable. The surgeon arrives with a leather bag. Inside are saws, knives, hooks and an iron rod heating over coals. No anesthetic exists, no antibiotic. Wait, the patient will be awake for every cut, every scrape of the saw against bone, every searing touch of the cautery iron sealing the stump. The survival rate hovers around 50% at best. So how did medieval surgeons perform this butchery and sometimes, somehow, keep their patients alive? Before we uncover the brutal techniques that turned amputation into a race against death, if you're fascinated by how medieval medicine walked the line between healing and horror, subscribe now. The most agonizing part is still ahead. Medieval surgeons didn't amputate for minor injuries. The decision to remove a limb came only when death was certain otherwise. Crushed bones that couldn't be set, deep wounds showing signs of gangrene, limbs mangled beyond recognition. These were the cases that ended on the amputation table. Physicians avoided surgery whenever possible because they knew the odds. More patients died from amputation than survived it. The process began with assessment. The surgeon examined the limb, checking how far the infection or damage had spread. The amputation had to occur above the diseased area, in healthy tissue, or the gangrene would simply continue upward. This meant that a crushed foot often required amputation at mid-calf. A gangrenous hand meant losing the forearm. The surgeon couldn't be conservative, leaving any infected tissue guaranteed death. Once the site was chosen, preparation began immediately. Speed was everything. The longer the patient remained under the knife, the more blood they lost, the deeper the shock, the lower their chance of survival. Surgeons aimed to complete the entire procedure in minutes, not hours. Every moment mattered. The patient was positioned and restrained. Amputation wasn't something you could perform on a cooperative subject. The pain was so extreme that even the strongest men thrashed, screamed and tried to escape. Assistants, usually 4 or 5 strong men, held the patient down. Leather straps bound the torso to the table. Arms were pinned. The limb to be amputated was extended and held motionless. Some surgeons gave the patient something to bite down on, a leather strap or a wooden rod, to prevent them from biting through their own tongue. Others offered wine or spirits beforehand, enough to dull the senses slightly but not enough to render the patient unconscious. Unconsciousness during surgery was dangerous. If the patient couldn't respond, the surgeon had no way to gauge whether they were slipping into fatal shock. Before the first cut, a tourniquet was applied. This was critical. A major artery, once severed, would pump blood with terrifying speed. Without a tourniquet, the patient could bleed out in minutes. The tourniquet was usually a thick rope or leather strap, twisted tight above the amputation site, using a wooden rod as a lever. The pressure was agonizing, cutting off all circulation, but it bought the surgeon precious time. The first incision came fast. The surgeon used a sharp knife to cut through the skin and muscle in a circular pattern around the limb. This wasn't delicate work. The blade sliced deep, down to the bone in one smooth motion. Blood welled immediately despite the tourniquet. Assistants used cloths to mop it away, trying to keep the field visible. The muscle was pulled back, exposing the bone. Some surgeons used retractors, metal hooks that held the flesh away from the cutting site. Others simply had assistants grip the tissue and pull. The bone, white and hard, now lay exposed. Then came the saw. Medieval amputation saws were brutal tools, large-toothed and aggressive. The surgeon placed the blade against the bone and began cutting with rapid strokes. The sound was horrific. The grinding of metal through bone, the cracking as the saw broke through, the wet scraping as it moved through marrow. The patient, fully conscious, felt and heard everything. Sawing through bone took time, sometimes several minutes depending on the thickness. The surgeon's assistants held the limb steady, preventing any movement that might cause the saw to slip and shatter the bone. A splintered break would create jagged edges that couldn't heal properly, guaranteeing infection. When the bone finally separated, the limb was removed and discarded. But the surgery was far from over. The stump, now raw and bleeding, had to be closed and sealed. The major blood vessels had to be tied off. This was delicate, dangerous work. The surgeon used curved needles and silk or linen thread to stitch around arteries and veins, closing them. Miss one vessel, and the patient could bleed internally for hours before dying. The thread had to be tight enough to stop blood flow, but not so tight that it cut through the vessel wall. Once the major vessels were secured, attention turned to the wound itself. Medieval surgeons faced a terrible choice. They could attempt to close the stump with stitches, pulling the skin flaps together over the raw bone, or they could cauterize it. Each method had risks. Stitching was cleaner but slower. It left the wound sealed, which helped prevent immediate infection. However, If any infection was already present inside the tissue, sealing the wound trapped it. The infection would fester internally, invisible, until it erupted days later. By then, the patient was often too weak to survive. Cauterization was faster and more brutal. The surgeon heated an iron rod in a brazier until it glowed red or white hot. Then, without hesitation, he pressed it directly against the raw stump. The searing heat burned through tissue, sealing blood vessels and creating a charred crust over the wound. The smell of burning flesh filled the room. The patient, if still conscious, experienced pain beyond description. The advantage of cautery was that extreme heat killed bacteria. Even though medieval surgeons didn't understand germ theory, they knew empirically that cauterized wounds got infected less often than stitched ones. The heat sterilized the surface, buying the patient a few extra days before infection could take hold. Many surgeons used both methods. They would cauterize the major vessels to seal them quickly, then stitch the skin flaps over the top, creating a closed wound with a cauterized interior. This combination offered the best chance of survival. Throughout the procedure, assistants monitored the patient's condition. If the patient stopped responding, if their skin turned gray, if their breathing became shallow, the surgery was halted. There was no point continuing if the patient was dying from shock. Some surgeons had techniques to revive failing patients: slapping the face, shouting, pouring cold water, anything to keep them conscious and fighting. The entire amputation, from first cut to final bandage, took between 10 and 30 minutes when performed by an experienced surgeon. Longer than that, and blood loss became fatal. Speed was the only anesthetic medieval surgery possessed. Once the stump was closed, bandages soaked in wine, vinegar, or herbal preparations were wrapped tightly around it. Wine was preferred because surgeons had observed that wounds treated with wine festered less often. They didn't know why. Alcohol's antiseptic properties were unknown, but the empirical evidence was clear. The patient was then moved to a recovery area, usually a bed in the surgeon's home, or a monastery infirmary. The real danger began now. For the next week, infection was the enemy. No antibiotics existed. If bacteria entered the wound, the patient's only defense was their own immune system. Surgeons checked the stump daily. They looked for signs of infection: redness spreading beyond the wound, swelling, heat, pus, foul odor. If infection appeared, the surgeon had limited options. He could reopen the wound, clean out the infected tissue, and cauterize again, or he could amputate higher up the limb, cutting away the infected stump entirely and starting over. Many patients didn't survive this second amputation. Their bodies, already weakened, couldn't endure another shock. They died within days, sometimes hours. Pain management after surgery was primitive. Opium-based preparations existed but were expensive and rare. Most patients received nothing stronger than wine or ale. They endured the throbbing, burning agony of a fresh amputation with no relief. Sleep was impossible. Many patients became delirious from pain and fever, thrashing in their beds, tearing at bandages. Fever almost always appeared within a few days. This was expected. Surgeons understood that fever indicated the body fighting. What they watched for was the quality of the fever. A moderate fever that broke after a few days was a good sign. A high fever that wouldn't subside meant the infection was winning. Some patients died from blood loss days after surgery. Internal bleeding, slow and insidious, drained them gradually. They grew pale, weak, confused. By the time the surgeon realized what was happening, it was too late. The patient slipped into unconsciousness and died. Others died from shock, delayed shock. The trauma of amputation could shut down vital organs days after the surgery seemed successful. The heart simply stopped, or the kidneys failed. Medieval physicians called this melancholia of the humors, or failure of the vital spirits, but they had no treatment. For those who survived the first week, the odds improved dramatically. If infection hadn't taken hold by day 7, it probably wouldn't. The stump would begin to granulate, new tissue forming over the wound. The pain would decrease slightly. The patient could begin eating solid food again and regaining strength. But survival didn't mean recovery was easy. The stump had to heal completely before the patient could consider any kind of prosthetic or crutch. This took months. During that time, the patient was bedridden or immobilized, dependent on others for every need. Muscle atrophy set in quickly. Even after the stump healed, learning to walk with a wooden leg or manage daily tasks with one arm required months of painful adjustment. Medieval surgeons developed techniques to improve survival rates, though success remained inconsistent. Some boiled their instruments before use, believing cleanliness mattered even if they didn't understand why. Others refused to operate on patients who were already feverish, knowing that surgery during active infection was nearly always fatal. Certain surgeons gained reputations for higher survival rates. These men were sought across regions, paid extraordinary fees, and their techniques were jealously guarded. Guild records mention amputation specialists who could remove a leg in under 5 minutes and claimed survival rates above 60%. Whether these claims were accurate or exaggerated is impossible to verify, but their reputation suggests some genuine skill. The psychological aftermath of amputation was rarely documented but must have been devastating. Losing a limb meant losing livelihood for most medieval people. A farmer couldn't plow, a soldier couldn't fight, a craftsman couldn't work. Many amputees became beggars, their stumps displayed to evoke pity and charity. Others were cared for by family or religious institutions, but they lived as dependents, stripped of autonomy and purpose. Class determined post-amputation fate. A noble who lost a leg in battle might retire to his estate with servants to assist him. He could still manage property, give orders, and maintain dignity. A peasant who lost a leg had no such options. He became a burden, a mouth to feed with no hands to labor. Some amputees commissioned prosthetics. Wooden legs, iron hands, these devices existed but were crude. A wooden peg leg allowed limited mobility, but was painful to use. The stump, still tender, rubbed against the wood with every step. Blisters, sores, and infections at the prosthetic interface were common. Many amputees abandoned their prosthetics and relied on crutches or crawling instead. The church offered one avenue of meaning for amputees. Some became symbols of sacrifice, especially those wounded in crusades or religious wars. They were housed in monastery infirmaries, given light duties, and presented as living examples of devotion. This offered dignity, but not independence. Medieval medical texts describe amputation techniques in clinical detail, but they rarely mention patient outcomes. The focus was on surgical procedure, not recovery. This suggests that surgeons viewed their job as ending when the limb was removed and the bleeding stopped. What happened afterward was God's will, not the surgeon's responsibility. How did medieval surgeons amputate limbs without killing patients? They worked with terrifying speed, cutting through flesh and bone in minutes. They tied off blood vessels with thread and sealed stumps with red-hot iron. They restrained screaming patients and ignored their pleas for mercy because hesitation meant death. They monitored for infection with no cure to offer if it appeared, and they watched half their patients die anyway despite every effort. Those who survived did so through pain tolerance, strong constitutions, and brutal luck. Medieval amputation wasn't medicine as we understand it. It was controlled violence, a calculated gamble that sometimes, against all odds, allowed a person to live minus the part of their body that was trying to kill them. If you enjoy the hidden sides of medieval life, hit subscribe and give this video a like.